Okay, well, thanks everybody. So, disclosure-wise, like I get some money from the government. I think really like the big disclosures, I am not today calling myself a gastroenterologist. I'm actually a Barry Foregut surgeon. But I do see patients, and I do endoscopy. And I think like a lot of you probably like the patients that I see for reflux surgery are not always evaluated or treated for reflux before they come to see me. So sometimes it is my job to do so and to try and be evidence-based in that way. And while I was asked to talk about the future of medical therapy for GERD today, and I'm trying to kind of intersperse some new findings and treatments, I think really the majority of this talk, if you want to know about the future, you should always sort of be like, thinking about the past, rooted in the past. So I'm going to do some talking today about, what we do right now for treatment of GERD and what we historically have done. Kind of for the overview today, like if I were to give a talk about, how to figure out if it was GERD, like that would be like an hour long. So I'm going to pepper it throughout this talk, but mainly, things that are new with lifestyle measures, when to prescribe, a little bit about the new AGA guidelines, some meds on the horizon, when to do endoscopy, and what you do when medical management fails. So I think first of all, like people that come to my clinic, maybe they like saw that they had a hiatal hernia on a CAT scan when they fell off their roof in the ER and got sent in. And, they sit down with me, we talk a little bit about, what their symptoms might be. I tell my residents always think about, like you're a plumber, right? So where's the lesion? Maybe the patient says they have heartburn, but they have like gastroparesis or they're on opiates. So you're kind of thinking about that. And then as you talk to them, you decide, this is probably like garden variety heartburn. The first thing that you should be doing is some lifestyle modification with them. So you talk to them about all these things that I think a lot of people, have learned in their residency or are doing in practice. You talk to them about weight loss, and I would say, like, that's my novel pearl for the day is, like, weight loss should be, like, a little bit of a conversation. It shouldn't be, like, give up caffeine. Talk to them about losing weight, but then, like, the modern thinking is enable them. So, refer them to a clinic that'll help them with it, someone that will prescribe a med if you feel like you don't want to. And for people that meet certain criteria, talk to them about bariatric surgery, right? So think about weight loss, but enable your patients who need that lifestyle modification. And so you talk to them a little bit and they have heartburn and they've had it for a few months and, maybe you're gonna see, would they respond to a medicine? So that's kind of the next step. So the American College of Gastroenterology has these guidelines from 2022. These are really nice if you're seeing a lot of these patients in clinic that are like mine where they're not really worked up. And so first step in their algorithm is, well, if they have reflux and it's impacting their quality of life and they don't have alarm symptoms, put them on a PPI. It bears like mentioning alarm symptoms, right? Okay, so dysphagia, unintentional weight loss, anemia, hematemesis. You're thinking about cancer and ulcers and strictures and EOE. Remember these Barrett's risk factors. Certainly I've seen people referred in for reflux that have more than just reflux. But maybe my modern pearl, because I also wear a bariatric surgery hat, is I think that history of prior gastroesophageal surgery should also be an alarm symptom. So maybe put that patient on a PPI, but if they've had a Nissen or a bypass or a sleeve, they're coming in to talk to you about reflux, like don't just medicate them, figure out why they're having reflux, like dive into studying them a little bit more. Surgery is an alarm symptom. And then what do you do? Well, American College of Gastroenterology says, okay, give them a trial. So you put them on 8 weeks of a once daily PPI. Make sure you tell them to take it, 30 minutes before a meal. And see how they do for a little bit. And so what PPI should you put them on? So there's been a lot of work in the medical sphere looking at the efficacy of different PPIs. And it turns out they're all probably pretty effective for treating esophagitis when you give it at the dose that it's supposed to be given at for that drug. There's a lot of variation in like the potency, like the pharmacologic potency of different PPI preps. And so, if you really want to kind of delve into medical management of reflux, there's this nice sort of standardization where, they think about omeprazole as kind of like, the standard, right? So this is the efficacy of like different PPIs and omeprazole units. What's new on the scene here? Well, There's a recent meta-analysis, kind of looking into this. They had 10 studies of different PPIs trying to cross-compare efficacy. About 15,000 patients were in these studies all total. And they sort of treated them per these ACG guidelines. So after about 8 weeks of therapy, they did a symptom assessment and they did endoscopy. And for esomeprazole, there was a 5% relative increase in the probability of healing erosive esophagitis compared to the other of the 7 PPIs in the study. But what that translated into is an absolute risk reduction of about 4%. And so you had to treat like 25 people to get a 4%, risk reduction for them. So really clinically, that doesn't necessarily translate into a lot of benefit for your patient. And so overall, the authors of the meta-analysis said, well, symptom relief and healing rates differ little among these PPIs. There's a new drug on the scene. I don't work for pharma. The drug is called vonoprazan, and it is a potassium competitive acid blocker. It inhibits the hydrogen potassium ATPase. Good things about the drug, so the half-life is apparently a lot longer. It does not require gastric acid secretion to activate. And it was approved by the FDA in 2023. In phase 3 studies, it was found to be more effective in reducing gastric pH compared to other commonly used PPIs. So maybe more to come about that drug, which is, as we see, relatively new. Another patient thing a lot of my patients will ask about is side effects. So a lot of people come in and, they're trying to decide between medicine and surgery and, boy, they don't like to take PPIs or, they're not a good surgical candidate maybe, and we're trying to treat them. And so there's a lot of discussion in the literature about all these different side effects related to PPI medication. This is a really nice study that was published in 2017, and it's basically a review of like all the randomized clinical trials looking at all of these side effects. And so for like the research nerds among us, like if a confidence interval crosses 1, it's not significant, right? And wide confidence intervals are not, the most convincing. So if you look at these for all of these common things that we're talking about, there's not really any like great RCT data that any of these like have like a strong like causal relationship with the side effect of interest. Same thing here for like special populations. Sometimes I'll have people with renal insufficiency come in. That one's a tough one because there's not really any RCTs. But for the most part here, for these other things, really the only thing that's like sort of moderately, maybe significant, is a little bit of an increased risk of non-C. diff enteric infections, which I think is interesting because I hear all the time about C. diff and PPIs. So, you can quote that data to your patients. The reference is up there. I can share that with anybody that wants it. But at any rate, you've put them on a PPI. Okay, so, they come back to the office 8 weeks later and they say, well, this PPI, it was great or it was terrible. And, if I'm a practicing, internist, now what do I do? I've asked them about alarm symptoms. I make sure that that's not going on. And then looking at this algorithm, so, either my patient has had incomplete control of their symptoms on the PPI after 8 weeks, or I stop the PPI and I give them like a 2 to 4 week kind of time period off of that and see, how do you do? I'm biased as a surgeon. I think everybody has terrible reflux, but a lot of people, that's all they need, is a little lifestyle modification. You take them off the med and life is better. If their symptoms come back, then you have to think about endoscopy. So what you want to do if you're being a purist, which is maybe a good idea when we're thinking about surgical candidacy for people, is you want to do your endoscopy with your patient off of their anti-reflux medicine. And so hold that medicine if your patient will tolerate it for 2 to 4 weeks, then do your endoscopy. And per this recent guideline, if you do that endoscopy and it looks normal, or they have LA grade A esophagitis, you need to dig a little bit deeper. If they have LA grade C or D or Barrett's, I think most of us are kind of used to like the Leon findings that that's GERD, right? Objectively, if you went and studied that patient, you would find that they had pathologic GERD. What's sort of newer, I guess, and more futuristic, like just in keeping with the theme of this talk, there was a multi-center retrospective trial that was published in early 2022 where they went back and they looked at all these folks that had, at many different centers, Los Angeles grade B esophagitis is an endoscopic finding, and found that there's actually like pretty good data that has a good objective correlation with reflux as well. So, the current guidelines say like may consider, stopping there versus doing your pH testing. That's also new and kind of, TBD as we study this LA grade B esophagitis group a little bit more. So then what do you do? Well, you can manage them medically, which, is not really my bag as a surgeon, but you can put people on PPIs indefinitely for LACD esophagitis. Give them the lowest dose that controls their symptoms. I think pertinent things, don't keep adding medicine to people who are non-responders. They're not responding on maximum dose PPI. You need to have a conversation about why that might be and dig into it a little bit. And then we see a lot of other things, at least in my part of the U.S., people on baclofen and prokinetics and Carafate. And really, when you look at the data, that's not the most effective, like adjunctive therapy. So things to consider. One adjunct that you can give that's kind of evidence-based is H2 receptor blockers. So these are nice at bedtime, for people who either have nocturnal symptoms and you haven't done objective pH testing yet, or you have somebody where you did that testing and they're having a lot of nocturnal reflux events. Failure of medical management. So that's the whole rest of this session maybe. So things to talk to your patients about when they come back and they've tried their PPI and it's just not working, right? So for those of us who are reflux surgeons or reflux proceduralists in the audience, we know that if somebody has complete non-response to a PPI, that should be a red flag to us that something else is going on. There's another etiology of the problem. If they have a partial response, well, here's some other things to consider. So are they taking their medicine at the right time? Remember, you want to be taking your meds 30 minutes before a meal, at least for the historical PPIs up until this new drug, for maximal efficacy. Interestingly, there's this gene that I actually learned about in researching this talk. So cytochrome P2C19 is present in about 10% of Caucasians, and it affects the bioavailability of PPIs. So some people are, more rapid metabolizers with certain variants of this gene. Some people are more slow. Interestingly, this new drug is supposed to act independent of this cytochrome. So, maybe some promise there for kind of people with refractory things. And then just thinking about other things that can, sort of present garden variety GERD, so alkaline reflux, post-operative patients with alkaline reflux hypersensitivity and functional heartburn. And because this is a 10-minute talk, I would just gently refer you to the Rome 4 criteria. These people do not do well if you operate on them necessarily. And then, some great pretenders. So achalasia, a lot of those patients subjectively feel like they're having reflux when really this is achalasia. Gastroparesis, strictures, cancers. We see a lot of eosinophilic strictures in my part of the country. So I think, just to circle back to the importance of doing endoscopy early on for people that fail their trial of PPI, rumination syndrome, so other things to think about. So in summary, is kind of the prologue to the rest of the talk. When you meet these patients in your clinic and all they have is that nice CAT scan from the ER, you have to sit down and think about, is it really GERD? Think like that plumber. Where's the lesion? Is it in the esophagus? Is it antropyloric discoordination? What's going on? Then take them through some lifestyle modification. And if you want to be, 2024, enable them for weight loss. Refer them. Don't just tell them to go out there and lose weight, because odds are they've already been trying to do that. Trial them on 8 weeks of a daily PPI. Then take them off, do a symptom reassessment, or if they fail, do your endoscopy. And go from there. So if they have LACD or Barrett's, chronic medical management versus surgical referral or surgery. LA grade B, if you're being futuristic, maybe that's enough objective evidence too for those patients. And then if they have a normal EGD or LA grade A esophagitis, do your dedicated pH testing, think about all those other causes, and be thoughtful. So thanks everybody for the invitation to speak today. And I think we're going to go right to the next person, right? Okay.